So at this time, we would like to welcome Dr. Walter Chan. Thank you, Walter.
Okay, great. So good morning. I'm going to be talking about an overview of esophageal disorders this morning. I have no relevant disclosure. I'm going to start our talk with clinical presentation of esophageal disorders, followed by going over some diagnostic tests we use for esophageal swallowing symptoms. And then I'm going to go over a few of the common disorders that we might see in the primary care and internal medicine settings. So in terms of clinical presentation of esophageal disorders, most common symptoms that we encounter for esophageal disorders include dysphagia, which often can indicate either mucosal inflammation, mechanical obstruction, or dysmotility. Often in patients with solids only, dysphagia may suggest a mechanical obstruction, while patients with dysmotility may have dysphagia to both solids and liquids. Obviously, this is not 100%. Odynophagia is also common. Usually when that occurs, it indicates some type of inflammation or ulceration. Chest pain, heartburn, regurgitation are some of the other common esophageal symptoms, as well as some extra esophageal symptoms such as weight loss, cough, choking, hoarseness, or dyspnea. In terms of physical examination, they're often normal, although in patients with severe symptoms, they may have signs of dehydration or malnutrition, such as hypotension or tachycardia. Also, there may be some signs or symptoms that may be associated with their underlying primary illness. For example, there might be oropharyngeal or dental signs if there are reflux that might be coming up to the oral cavity or the oropharynx. There might be pulmonary or airway issues in patients who are either aspirating or having significant reflux or regurgitation coming back up. Patients with underlying autoimmune conditions may have skin symptoms or signs, such as patients with scleroderma, and also with musculoskeletal symptoms. When we think about patients presenting with esophageal dysphagia, then we can often separate them into a few main categories based on the underlying pathophysiology, including patient with mechanical obstructions, such as a mass or a ring or stricture, patient with mucosal diseases, including patients with esophagitis, reflux, or other caustic injury, patient with a primary motility disorder, such as achalasia, and patients with functional disorder, such as visual hypersensitivity. How do we usually diagnose esophageal and swallowing disorders? And I'm going to start with our first case of the session today, which is a case of a 75-year-old woman with a history of diabetes, hypertension, coronary artery disease, and CVA and GERD, who came in with evaluation of swallowing symptoms. She described her symptoms as a sensation of food sticking in her throat region when swallowing. The symptoms may occur with both liquids and solids. She also noticed frequent coughing with eating as well, but denies any odynophagia. She reports some heartburn after meals, but it has improved with the use of a PPI. So the question is, what is the most appropriate next step in evaluation of this patient's symptoms? Would you choose to do a barium swallow, an upper endoscopy, a chest CT, an esophageal manometry of the impedance, or a modified barium swallow based on the case history of the last patient? So it seems like we have a variety of selections by our participants, with probably the most selections being the modified barium swallow, but also a few choosing barium swallow upper endoscopy, a smaller number choosing esophageal manometry. So let's go over some of these diagnostic techniques, and we'll come back to the case and talk about what the most appropriate testing will be for these patients. Some of the diagnostic modality we have the swallowing symptoms, including imaging studies. One of the most common one we see is a video fluoroscopic swallow study or modified barium swallow. This is mainly used to, often performed with the help of a speech pathologist, mainly used to assess oropharyngeal bolus transport. So any oropharyngeal symptoms, oropharyngeal dysphagia, this will be the best test to use. It can also help evaluate structural abnormalities of the oropharynx or in the upper esophagus. So a Zenker's diverticulum can often be seen very well with the modified barium swallow. In contrast, full column esophagram or barium swallow is mainly used to evaluate for any esophageal obstructive lesions, strictures, diverticulum of the esophageal body. Sometimes it may help with this demonstrate characteristic changes of certain motility disorders, such as achalasia, can give you that bird speak appearance, or a hiatal hernia or reflux. Endoscopy is another common use modality to evaluate for any swallowing symptoms. Mainly, it can help us rule out any mechanical obstructions such as malignancy, a foreign body, or even stricture, ring, or web. But importantly, it can also help us assess and biopsy any abnormal mucosa. For example, if there's the infectious changes, any inflammation from either GERD or caustic injury, or eosinophilic esophagitis as seen in this picture here. Esophageal manometry helps us diagnose any motility disorders. It involves a transnasal passage of the catheter with pressure sensors throughout into the esophagus and stomach. Usually, patients, we would do this test when we want to assess any abnormal esophageal contractile activity or to identify any anatomic landmarks. It can help us diagnose any motility disorders and also help us place, in place correctly placing a pH probe. It is used often for preoperative evaluation of anti-reflux surgery and also other chest and esophageal surgeries as well. An ambulatory pH monitoring involves continuously recording distal esophageal pH to quantify the amount of reflux over a study period. It can be done in two ways. One is by a transnasal probe with a pH probe. The other is by endoscopically placing a pH capsule into the clipping onto the esophagus. Patient will also carry a device that records data from the capsule or the probe, and patient can also press a button to report their symptoms to allow us to correlate between patient-reported symptoms and any reflux events. Intraluminal impedance is one of the newer modalities. It's involved the use of impedance technology, which is a representation of resistance to a change in electrical current from any transit of bolus throughout the esophagus. So liquid compared to air has lower resistance, which actually gives us a lower impedance as well. So whenever liquid passes either going up or down our esophagus, we'll see a drop in impedance as it passes through different levels of the esophagus that will help us see whether the liquid bolus the patient is drinking is going down appropriately, or if there's a significant amount of reflux coming back up. It is often combined with manometry or pH probe. So when impedance combined with manometry, it can help us see how well the bolus is being transiting through the esophagus, or if it's combined with a pH monitoring, it can help us measure reflux coming back up regardless of the pH level. So we can identify for either acid reflux or even non-acid reflux compared to just using a pH probe alone. So going back to the case, if you remember the case, the patient came in with a lot of oropharyngeal symptoms. She feel like the food's getting stuck in her throat region. And also she was having a lot of coughing with eating, which makes us suspect an oropharyngeal dysphagia or oropharyngeal etiology of her swallowing symptoms. So a modified barium swallow will be the best modality in evaluating for oropharyngeal dysphagia. The other choices, like the full column barium swallow, the upper endoscopy, and the esophageal manometry, are all for evaluating esophageal symptoms, but doesn't provide enough information on the oropharynx. And the chest CT is obviously not the most useful test in evaluating swallow symptoms unless we're looking for extraluminal causes that might be obstructing the esophagus. We're going to move on to some esophageal disorders. The first one to talk about commonly is GERD. GERD, as we know, is a very common condition affecting up to 40% of healthy adults. It tends to be equal in terms of affecting male and female, although severe disease like reflux esophagitis and Barrett's esophagitis tend to be more common in men. The prevalence of GERD also increases with age, although the mean age of diagnosis is around 40 years old. In terms of pathophysiology of GERD, the important thing to remember is that reflux is actually physiologically normal. Usually when we eat, there's some level of reflux that might happen, and it can be the reflux that most commonly we think about gastric acid, but bile, pancreatic secretions of food matter can also come back up sometimes, especially around mealtime. Pathologic reflux usually results when there's irritation of the esophagus that can occur from these refluxate exposure, either due to an increase in acid or refluxate exposure, or decrease in barrier, esophageal mucosal barrier to these irritation causing injury to the esophagus. And reflux can happen due to dysfunction in three main areas, either at the esophagus level, at the lower esophageal sphincter level, or in the stomach. And usually with the esophagus, if there's impaired motility or decrease in epithelial barrier function, that can lead to more reflux symptoms. If you have a weak lower esophageal sphincter or inappropriate relaxation of the lower esophageal sphincter, even when you're not eating, then you can get a lot of reflux. With the stomach, with delayed emptying or increase in acid exposure, acid production, or even a hiatal hernia can lead to more reflux as well. Some of the other factors commonly seen, obesity, pregnancy, or any hormonal changes can lead to more reflux, as well as medications or ingestion of certain food, alcohol, or tobacco. Clinical presentation of GERD can be mainly divided into esophageal symptoms and extraesophageal manifestations. So in terms of esophageal symptoms, the most typical symptoms we think about are heartburn and regurgitation. Some of the less typical esophageal symptoms include chest pain, dysphagia, odynophagia, nausea, or even a global sensation of epigastric pain. Extraesophageal manifestations include hoarseness, sore throat, cough, postnasal drip, some of the ear, nose, and throat symptoms, as well as some pulmonary conditions like asthma, COPD, or interstitial lung disease. So the second case of today is a 70-year-old man with a history of Alzheimer's disease who came in for evaluation of reflux symptoms for 2 months. He describes a heartburn sensation and regurgitation that is worse with eating or lying down. He denies any dysphagia, odynophagia, abdominal pain, or nausea. He's never had any similar symptoms in the past. He's tried taking over-the-counter antacids and an H2 blocker, but without adequate relief of his symptoms. So the question is, which of the following is an appropriate next step in the management? Is it A, starting an omeprazole 20 milligrams at bedtime for his nocturnal symptoms? B, trial of metoclopramide? C, avoid PPI because he has a history of Alzheimer's? D, perform an upper endoscopy? Or E, perform a 24-hour pH monitoring? So it seems like we have a majority suggesting starting omeprazole at that time for nocturnal symptoms, a smaller percentage choosing upper endoscopy. So let's go over some of the data on what we know about managing GERD, and we'll come back to this question. So what are some of the ways we manage reflux? The first line is often lifestyle modification, including dietary modification by avoiding trigger food items, and also suggesting to patients to eat smaller meals. Multiple small meals are usually better for patients. Avoiding lying down for about 2 to 3 hours after eating is another way to help reduce reflux. Tobacco cessation, elevating the head of the bed when sleeping, especially for those with nocturnal symptoms, and weight loss are some of the other strategies. In fact, elevating the head of bed and weight loss are the two strategies with the best evidence in improving GERD symptoms. In terms of medical management, empiric acid suppression therapy is often the first line. We often start with a trial of 8 weeks of therapy and titrate the dose according to the severity of symptoms. In terms of acid suppression therapy, PPI is best administered about 15 to 30 minutes before meals. The key is always try to taper the dose when patients start responding with their symptoms. The goal is to manage the symptoms with the lowest possible dose. And the reason that PPI use is important to be taken before meals, the one thing to emphasize to the patient is the key is that you want to eat something after you take the medications, because food triggers upregulation of the proton pumps in her stomach, so that when you if you take the medication, take the medication before you eat, by the time you metabolize the drug and for it to act, there will be enough proton pumps around for it to block, to maximize the therapy. So the key really is that patients should be eating after the medications in 15 to 30 minutes to allow maximal efficacy of the PPI. There's some risk factors for PPI failure, including longer duration of disease, patient with a hiatus of hernia, those with extraesophageal symptoms, and also patients with low compliance. In terms of pregnant patients, antacids and H2 blockers are both safe. PPI is actually also safe to use, with the only exception being omeprazole, which is category C. That's more due to a lack of data rather than actually reported adverse events. One of the common questions that we get is, what are the adverse effects of PPI? In terms of acute side effect, that's actually really rare and happens in less than 2%, commonly involving headache, diarrhea, constipation, or abdominal pain. There's been some reports of an increased risk of community-acquired pneumonia in elderly patients with short-term usage upon initiation of the PPI. Although this data is somewhat disputed, mainly because it involves retrospective data, and there are thoughts that maybe there's some confounding to this data that's led to this association rather than a true causation by PPI. In terms of chronic PPI use, there have been reported of malabsorption of vitamin B12, calcium, and magnesium with suppression of the acid. There's a lot of studies that have done looking at osteoporosis and hip fracture in high-risk groups, particularly due to the decreased absorption of calcium. Bacterial gastroenteritis and C. difficile infection have also both been reported to be associated with chronic PPI use, as well as small intestinal bacterial overgrowth. There's some newer suggestions, suggested association between PPI and some chronic effects, including cardiovascular events, although on further investigation had not been any evidence found between true causation of PPI with cardiovascular events. Chronic renal insufficiency has been suggested, although we need further data to actually validate it. Dementia has also been suggested initially, although there have been multiple subsequent large studies that have found no evidence of association between PPI use and dementia. The next, one of the things that we do is we have to consider is, when do we proceed to further management of evaluation of GERD, including performing endoscopy and further diagnostic testing. Some of the things that we look for are patients who come in with alarming features, including dysphagia, dinophagia, weight loss, any signs of bleeding, vomiting, any abnormal imaging, or known family history of upper GI malignancy. Older patients, greater than 50 and presenting with new onset symptoms is another alarm features, as well as patients who are non-responder to medical therapy. What do we do if patients don't respond to PPI in the first place? There are actually very limited options. You can either, first thing I usually tell a patient to do is optimize the timing of PPI, make sure they're taking it before their meals and make sure that they're compliant. We can consider doing esophageal function testing, including manometry and pH monitor to see how much reflux they actually have, or if there's a motility disorder that could be causing their symptoms. You can add an H2 blocker if they have nocturnal sleep symptoms. If they tell you that mostly the symptoms are worse when they're sleeping or lying down, adding an H2 blocker might be helpful. They're most beneficial if they already have pH testing showing overnight acid reflux. There really is no role for metoclopramide in patients without known gastroparesis or evidence of gastroparesis. Some neuromodulators might be helpful if you think patients might have hypersensitivity to reflux, such as TCA. And you may also consider a GABA B receptor agonist as a reflux inhibitor, such as baclofen. Baclofen has been shown to decrease acid exposure, decrease reflux episodes, decrease transient lower esophageal sphincter relaxation, and increase lower esophageal sphincter pressure, thereby helping reflux symptoms. Although the use of baclofen is often limited by the side effects such as dizziness and somnolence. What about beyond medical therapy? Anti-reflux surgery can also be considered. Indications for anti-reflux surgery include failed intolerant to medical therapy, patients who are very medication dependent, they can't get off the acid suppression. The main one that's being done now is fundoplication, which relieves GERD symptoms in over 90% of patients when performed. It can be performed either laparoscopically or with laparotomy, which have comparable results in 10-year outcome. The main adverse events associated with fundoplication is patients sometimes can develop this gas bloat syndrome or some swallowing symptoms afterwards, although they usually tend to be short-lived. In terms of patients who are overweight, bariatric surgery may be more effective than fundoplication among obese patients. The main one that's been shown to provide the most reflux relief is Roux-en-Y gastric bypass, more so than gastric band, which is not really done much anymore, or sleeve gastrectomy. So going back to this patient, we talk about he's a 70-something-year-old patient who came in with new onset reflux symptoms that he never had before, only about 3-month duration. He's tried an H2 blocker and it didn't work, and still continue to have symptoms, mostly nocturnal symptoms. So in this patient, the first thing, usually, even though normally we would think about starting an empiric acid suppression first, because he's an older patient with new onset symptoms in short duration, I would actually start with an early upper endoscopy, make sure that this is not a symptom of a new malignancy of some sort. Remember, he's a 70-something-year-old with a smoking history. They come in with new symptoms. Starting omeprazole is reasonable. You don't have to avoid it, even though he has a history of Alzheimer's. We talk about the data regarding dementia. Although, remember, we want to start PPI and have patients take them 15 to 30 minutes before meals. So if you think about nocturnal symptoms, an H2 blocker at bedtime would be a better option. And omeprazole, in fact, wouldn't work terribly well because the patient wouldn't be eating after. Metoclopramide would not be appropriate in this patient without gastroparesis, and 24-hour pH monitoring is a little too early right now before we tried other things. So the third case I want to talk about is a 40-year-old woman with no significant past medical history who presented to the emergency department with chest pain episodes over the past week. She described sharp pain in her substernal region with no association with exertion, positional changes, or eating. She was admitted for management and cardiac evaluation, including stress tests, which were all negative. Her symptoms were felt to be most likely of an esophageal origin, but she denied any dysphagia, odynophagia, nausea, vomiting, heartburn, reflux, or regurgitation symptoms, really just the pain. All lab evaluations are remarkable, and she had no other complaints. So the question is, what is the most appropriate next step for management of this patient? Is it performing a barium swallow, starting empirically on the PPI, do an upper endoscopy with mucosal biopsies, a manometry impedance study, or an empiric trial of a smooth muscle relaxant for spasms, such as a calcium channel blocker? So it seems like with a pretty even selection between a trial of a PPI and performing esophageal manometry, a smaller number suggests that maybe trialing a smooth muscle relaxant. So let's talk about patients coming with non-cardiac chest pain. The important thing to remember in patients with non-cardiac chest pain is that the etiology of it. The most common etiologies are actually GERD or functional chest pain, as seen in epidemiologic studies. And primary esophageal motor disorder is really only accounting for a small minority of patients with non-cardiac chest pain. So we often think about spasm, but it's actually often not a common cause of non-cardiac chest pain. So when we evaluate for patients and manage patients with non-cardiac chest pain, first thing we want to rule out cardiac causes. But the next thing to do is actually manage reflux, including lifestyle modification, empiric PPI. If they don't respond, then you think about doing an upper endoscopy or even pH monitoring or manometry. Starting an empiric trial of a calcium channel blocker is actually not recommended because remember, GERD is the most common cause, and smooth muscle relaxants tend to increase reflux. So if you just empirically start them on a smooth muscle relaxant, they may actually make their symptoms worse. So the answer to this question is actually an empiric proton pump inhibitor for non-cardiac chest pain as a first-line therapy. The next part I'm going to talk about Barrett's esophagus. I'm going to start with another case of a 45-year-old African-American woman with a history of GERD who came in for annual physical examination. She has been doing well, has no complaints. She has had reflux symptoms. They're well controlled with the use of omeprazole 200 milligrams once daily. She previously tried coming off the medication, but her symptoms later recurred, so she stayed on the medications. She has no dysphagia. She has no odonophagia, abdominal pain, nausea, and vomiting. She's been eating normally, has a healthy diet, her weight is stable, no tobacco or alcohol use, no significant past medical history, family history, and her physical exam is completely normal. She wanted to ask you about screening for Barrett's esophagus because she has a history of reflux. Which of the following strategy would you recommend? Would you prefer an upper endoscopy now and do it every 10 years, or do it every 5 years after, or every 3 years after, or every 1 year after, or starting screening at age 50, or not doing one at all? So it seems like the majority have chosen no endoscopy indicated. So what is the current guideline for managing or evaluating for potential Barrett's esophagus? So we know the Barrett's esophagus is a replacement of normal distal esophageal squamous epithelium by intestinal metaplasia. The concern, the sequence is that patients with chronic reflux may have esophagitis that develop metaplastic changes. Overall prevalence in the US is about 5.6%, but much higher in patients with reflux. The main risk factors are patients who are Caucasian, who are older, who are obese, who are men, and those who have tobacco and alcohol use. The concern is that it increases the risk of esophageal and adenocarcinoma. Do we screen for Barrett's esophagus? There's currently no screening recommendation for the general population. The current guidelines suggest that you may consider screening some patients who have multiple risk factors associated with Barrett's, including those who are older, who are men, who are Caucasian, who have chronic reflux with hydrohernia, who have elevated BMI or an intra-abdominal distribution of body fat. If you don't have multiple risk factors, then there's no screening recommended. For those who do have Barrett's esophagus on first endoscopy, then surveillance is needed, ranging from 3 to 5 years for those with no dysplasia, to patient with dysplasia needing sooner surveillance or performing endoscopic therapy. The type of endoscopic therapy we can perform include endoscopic mucosal resection or radiofrequency ablation only in those with dysplastic Barrett's, not in those with no dysplasia. Even after the endoscopic therapy, the patient will require continuous surveillance. There's some evidence that chemoprevention might help. For example, PPI has been shown to reduce neoplastic progression in patients with Barrett's. Aspirin and NSAIDs have been shown to reduce risk of esophageal cancer. And most recently, there's been a trial that's shown that a combination of high-dose PPI and aspirin among Barrett's patients decreases time to mortality, esophageal cancer, or high-grade dysplasia. So going back to case 4, this patient who is healthy, who is an African-American woman, young, who's thin, doesn't smoke, doesn't drink, no family history, there really is no endoscopy indicated because she doesn't really have many risk factors. I'm going to move on to talk about some motility disorders. Usually we think about motility disorder, we can classify them by the abnormality of the innervation, including abnormal inhibitory innervation, such as patients with achalasia or diffuse esophageal spasm, or to patients with disorders of excitatory innervation and smooth muscle, including those with scleroderma or jackhammer or nutcracker esophagus. I'm going to start this part of it with another case of a 70-year-old man who came in with worsening dysphagia for 3 months. He described sensation of food getting stuck in his mid-chest region while swallowing. The symptoms are words with solids and liquids. He may also sometimes have to regurgitate food bolus back up. Because of his symptoms, he has been having increasing difficulty in tolerating his oral diet. He's lost about 15 pounds in the last few months since the onset of his symptoms. He underwent an evaluation with an upper endoscopy that was normal, had an esophageal manometry that was done that showed a poorly relaxing lower esophageal sphincter and an aperistaltic esophagus that's consistent with achalasia. So the question is, what should be the next step of management in this 70-year-old man that was diagnosed with achalasia because of the swallowing symptoms for 3 months? Would you refer him for an endoscopic Botox therapy to his lower esophageal sphincter, a trial of smooth muscle relaxant to relax his lower esophageal sphincter like a calcium channel blocker or nitrates, performing a CT of the chest, abdomen, and pelvis, referring him for surgical myotomy to cut the lower esophageal sphincter, doing a pneumatic dilation of his esophagus, lower esophageal sphincter to help him, or doing a barium swallow study at this point with a barium tablet. So it seems like most have chosen endoscopic Botox therapy as the next step. Pneumatic dilation is the second choice here, it seems like, and then smaller number of patients chose either smooth muscle relaxant or performing CT scan. So let's go over what we know about achalasia. As we know, it's a preferential degeneration of the postganglionic inhibitory neurons in the myenteric plexus that results in insufficient relaxation of the lower esophageal sphincter with swallowing, and also aperistalsis of the esophageal body. It is very most commonly between the ages of 25 to 50, with an equal prevalence between male and female. One thing to remember is that patients with achalasia has a 16-fold increase in the risk of squamous cell carcinoma, often found an average of 14 years after the achalasia diagnosis. Usually, what causes achalasia? In terms of primary achalasia, it's most often idiopathic, although there's been some suggestions that there might be some underlying autoimmune or viral causes. Patients with idiopathic or primary achalasia generally have a gradual onset of symptoms with insidious progression. Mean duration of symptoms to diagnosis is usually about 5 years. Secondary achalasias are patients who have other conditions leading to an achalasia pattern in the esophagus. Chagas disease is one that we know about, but the one that we most commonly see in terms of secondary achalasia is a malignancy, which can be a malignancy of the GE junction or even a distant malignancy causing a paraneoplastic syndrome leading to esophageal dysmotility and an achalasia pattern. The key is that these patients often have a more acute onset and more rapidly progressive symptoms compared to primary achalasia. So they can come in with symptoms for just months and rapidly deteriorating. The most common symptoms are dysphagia, which happens in nearly 100% of patients, but patients may also complain of regurgitation, difficulty belching, chest pain or heartburn, and even weight loss. There's some lab study that might be useful, especially if you're looking for an underlying cause, such as antineuronal antibodies, but often lab studies are normal. Endoscopy is often normal as well, with many use to rule any mechanical obstruction. Barium swallows may show a bird's beak appearance, although not all the time. Also a dilated esophagus and no peristalsis of the esophageal body. Manometry generally shows an abnormal relaxation of the lower esophageal sphincter swallowing and an aperistalsis of the esophageal body. In terms of treatment of achalasia, there are a few categories. The first, including pneumatic dilation, myotomy, which can be done surgically or through endoscopy, Botox injection to the lower esophageal sphincter, and using smooth muscle relaxant. As you can see, the first three, pneumatic dilation or the two myotomy options, have very generally great response, both at 2 years and at 5 years, upward of 80 to 90% have good response. Compared to Botox injection and calcium channel blocker, which generally have lower response. Botox usually have good response initially, but generally it will decrease over time. And smooth muscle relaxant just generally don't have great response, usually around 50% or so. But obviously, pneumatic dilation and the myotomies are more invasive procedures. They carry risks of perforation and surgical risk as well. So those are for those, we generally reserve for patients who are high surgical risk compared to Botox and smooth muscle relaxant. We generally use for patients with lower surgical risk. So in those, I reverse. So low surgical risk, we want to do either pneumatic dilation or myotomy. And if they fail, you can then think about repeating and doing the other therapy. It's high surgical risk patients, we would generally do Botox or if they fail smooth muscle relaxant because of potential complications. So in terms of this patient, what should we do? This is an older patient, 70-something years old, that came in with dysphagia for 3 months, lost about 20 pounds in a few months, never had these symptoms before, and diagnosed with achalasia. Before we think about doing any sort of treatment, we need to think about whether this patient might have a secondary cause of achalasia, so including malignancy. So the first thing that I would do is actually do a CT of chest, abdomen, and pelvis to actually rule any distant malignancy before thinking about the next step of therapy in patients who present with these type of rapidly progressive symptoms. I'm going to quickly go through a couple other motility disorder, including diffuse esophageal spasm, mainly involving the impairment of inhibitory innervation of the esophageal body. These patients generally have simultaneous contractions of the esophageal body, but normal lower esophageal sphincter relaxation. These patients generally often come in with chest pain, but also can come in with dysphagia or regurgitation. Barium swallow, they generally have a characteristic kind of corkscrew type appearance that you can see here. On manometry, you can see a sort of spastic simultaneous contraction for the normal lower esophageal sphincter. The treatment generally involves the use of acid suppression because often reflux can trigger these findings sometimes. But in patients who have no reflux, then you can think about using smooth muscle relaxants like a calcium channel blocker, nitrates, or anticholinergics. Pain modulators may be useful in some patients, and also dilation, Botox, myotomy in a small number of patients that don't respond to their medical therapy. Generally, patients have intermittent symptoms or are non-progressive, but a very small percentage of them can actually progress to achalasia. And there's a table that I'm not going to really go over in detail, but just some list of some motility disorders classified as either hyper or hypomotility disorder. The one thing I want to point out here is that, as you can see, GERD is a common cause of both hypo and hypermotility disorder, or a consequence of either one. So oftentimes the first line of treatment is anti-reflux therapy before progressing to other type of therapy for either hypo or hypermotility esophageal disorders. So next, I'm going to talk about eosinophilic esophagitis. The next case is a 20-year-old man with a history of eczema and chronic dysphagia who presents for follow-up after an incident of food impaction for which he underwent urgent upper endoscopy in the emergency department. A repeat upper endoscopy was performed, and this is the image that was showing what was found. Mucosal biopsies were obtained, revealing greater than 80 eosinophils per high power field. He continues to report intermittent dysphagia symptoms when eating solid food, but no further food impaction episode. He denies any chest pain, heartburn, reflux, or regurgitation. So the question is, what is the most appropriate next step in the management? Is it A, initiate treatment with cromolyn, a mast cell stabilizer, B, schedule an esophageal manometry, C, initiate treatment with swallowfluticasone for 8 weeks, D, start twice daily proton pump inhibitor, or E, repeat upper endoscopy for dilation? Before we talk about the answers, I'm going to quickly talk about eosinophilic esophagitis. It is clinically characterized by symptoms related to esophageal dysfunction. It's diagnosed pathologically by having at least one biopsy specimen from the esophagus showing eosinophil predominant inflammation that's currently defined as greater than or equal to 15 eosinophils per high power field. The disease is generally isolated to the esophagus, and other causes of esophageal eosinophilia are excluded. The patient population with eosinophilic esophagitis are generally male and of younger age. Some patients even were even diagnosed when they're children. The mean symptom duration before diagnosis is usually 5 years, and the vast majority of these patients have a history of allergic conditions. The main symptoms are dysphagia in up to 82% of patients, but some patients may also report heartburn and chest pain. Food impaction is common among patients with eosinophilic esophagitis. Up to 55% of adults with EOE have an episode of food impaction. In patients coming in with food impaction, about 55%, up to 55% are ultimately diagnosed with EOE as well. On endoscopy, you can see signs of these ringed esophagus, as shown here. This longitudinal furrows going down. Sometimes you can see white patches and maybe a small caliber esophagus or even strictures. There are several main treatment that's proven and recommended for EOE. Proton pump inhibitors, topical steroid therapy, including swallowfluticasone or budesonide slurry, an elimination diet, either empirically or based on allergy testing, and also endoscopic dilation of any strictures that are found. There are a few experimental therapies that are really currently only recommended in setting of clinical trials, including several biologics, including anti-IL-5, IL-13, and anti-IgE antibodies. Also, montelukast, cromolyn, or other immunomodulators have been studied as well, and also and have clinical trials that are ongoing. The main thing, though, is that maintenance therapy is recommended even after treating these patients and you achieve remission, because there's a high risk of recurrence of disease if you discontinue therapy. So whether you choose PPI, topical steroids, or elimination diet, that's something that patients should continue on a maintenance for. So going back to the case, in this patient diagnosed with likely eosinophilic esophagitis, given greater than 80 eosinophils per high power field and history of dysphagia and food impaction, what is the most appropriate next step in management? And the answer is starting a twice daily proton pump inhibitor. Study had found that up to 50 to 60% of patients started on twice daily proton pump inhibitor achieve histologic response in patients with eosinophilic esophagitis. Mast cell stabilizer, which is answer A, has not been found to be effective yet and is still experimental. Esophageal manometry is really not part of the management algorithm for EOE. Topical steroid is a treatment option for EOE, although maintenance therapy is recommended due to the risk of recurrence, so not just an 8-week therapy. Endoscopic dilation may be performed for presence of strictures, which was not seen in this patient's endoscopy. And lastly, I'm going to quickly go over a few other esophagitis that you might see in patients presenting. Infectious esophagitis most commonly come in with odynophagia in addition to dysphagia. They most often develop in patients that are immunocompromised, including patients with HIV, on chemotherapy, or transplant patients. Candidial is the most frequent cause of infectious esophagitis. It's most often associated with oral candidiasis as well. Upper endoscopy with biopsy is the most sensitive and specific test for them, and the characteristic appearance is these whitish plaques we might see throughout the esophagus. Treatment typically involves systematically treating with an oral azoles like fluconazole. Viral esophagitis can also be seen most often with herpes simplex virus or cytomegalovirus. These are most often seen in transplant recipients, and diagnosis often require an upper endoscopy with esophageal brushing, viral culture, or biopsies. Characteristically, you can see these mucosal ulcerations throughout the esophagus. Treatment are basically antiviral systemically for treating HSV or CMV, including cyclovir, ganciclovir, or forscarnet. Pill esophagitis can sometimes be seen as well. Often patients may come in with dysphagia or odynophagia. The common drugs that can cause pill esophagitis are antibiotics, NSAIDs, bisphosphonates, some potassium pills which are large, and some iron pills as well. Most patients have normal underlying esophageal structure and function, but some risk factors that might put patients at higher risk of pill esophagitis are either advanced age, patients with underlying esophageal dysmotility, any sort of extrinsic esophageal compression that might cause the pill to be held up, a large pill size, or swallowing pills without water or in a supine position. So finally, I'm going to go over some key points that we went over during this lecture. First of all, lifestyle modification and empiric acid suppression trial are the first-line approach on complicated GERD. In managing GERD symptoms, endoscopy and other diagnostic studies should be reserved for patients with alarm features, who are older age with symptom onset, or those who fail medical therapy. Dose tapering of PPI should always be attempted once symptom response is achieved. The most common cause of non-cardiac chest pain is gastroesophageal reflux disease, followed by functional chest pain. Management strategies for GERD should be followed once cardiac causes have been ruled out. In terms of achalasia, secondary or pseudoachalasia should be ruled out in patients diagnosed with achalasia, especially in older patients who have rapid onset of symptoms and rapid deterioration. Management strategy of primary achalasia should depend on the patient's surgical risk, with the lower surgical risk patients undergoing definitive therapies like pneumatic dilation or myotomy. Esophageal biopsies to assess for eosinophilia should be performed for the workup of dysphagia. And recommended treatment options for EOE include PPI therapy, topical steroids, or elimination diet. Importantly, maintenance therapy is indicated due to the high risk of recurrence if therapy were to be stopped. Odynophagia is the most common symptom for infectious esophagitis, and they usually occur in immunocompromised patients, with Candida being the most common agent. Medications at higher risk for causing pill esophagitis include NSAID, antibiotics, bisphosphonate, and potassium tablets. Thank you.
I do have one or two audience questions, if I could ask you, Dr. Chan. These are quite great questions. One of the questions is, in patients with esophageal dysphagia, are there any particular symptoms that would help you to decide whether to do just a barium swallow first or go straight to the endoscopy? Are there anything that make you?
So that's actually a great question. Usually patients with any sort of alarming symptoms, we generally would do an upper endoscopy first. There's actually a great debate among a lot of gastroenterologists as well in terms of whether barium swallow is actually even useful before doing if you're thinking about doing an upper endoscopy anyway. I think patients who have, especially solid food dysphagia, any pain type symptoms, odynophagia, are the ones that you want to do an upper endoscopy, because you have the advantage of getting mucosal biopsies that barium swallow wouldn't give you.
Great. And then one last question for patients with severe GERD, is twice daily dosing of PPI better than once daily dosing to control the symptoms?
There has been a lot of the evidence have actually shown that twice daily PPI does give you additional benefit. So if someone who's on, let's say, omeprazole 20 grams once daily, they're not doing better, you want to increase the dosing. Study have shown that 20 twice a day is better than 40 once a day if you have to increase dosage. There hasn't, but if they don't respond to that, going up further to 40 twice a day actually hasn't been shown to provide additional benefit. But 20 twice a day does give you more benefit compared to 40 once a day.
Thank you so very much. That was excellent.